holding down the fort at home, but as Mr. John said, so I'm what they call an independent patient advocate. David and I started this business we started like 5 years ago. We started our LLC in March 5 years ago. But my background is I'm a nurse by trade, and my husband is a respiratory therapist. So I was, like Mr. John said, I'm Canadian, so I was born and raised in northeast Canada, all the way up there in Newfoundland. So we are very Irish broguish descendants. So let me tell you, when I moved to Carteret County 20-something years ago, the first time I came here, some of my patients at Carteret, it was called Carteret General then. Yeah. I'll tell you a little story. I had this man come with me, was my patient one night. I worked in the ICU, and I walked in, I started talking to him, and he said, you sound like you should be from Harker's Island, but you're not from Harker's Island. Because I know everybody at Harker's Island. And I said, no, I'm not, sir. And I said, but I said I'm from Canada. And he said, well, where? And I said, Newfoundland. I said, so now I refer to everybody when they get mixed up in my accent. I say I'm from down east, but down east Canada. And then that seems to do the trick. And I married a Southerner. My husband I met at Wake Med, and we got married in 2001, so I have some Irish brogue, I have some Canadian, and then there's some Southern drawl, so it's just, yeah, so we go back to down East Canada. That seems to work.
Do you speak French also?
So I was raised to learn French all through school, but I did not do French immersion, and my family was not French, so no, I did not, but I was entrenched in it, of course, in the Canadian, because it's a bilingual country, but
I tend to understand English better anyways.
There you go. I say we call it the Newfoundlandese, where I do have some Newfie slang in there every now and then, so if I get mixed up, then you'll know why, but that would be it. So I moved to the U.S. after I finished nursing school, started at Wake Med, and then worked. I've been nursing for feels like forever, but I've been in healthcare for 30 years, and my husband is about the same in RT. And then, like we said, 5 years ago, we decided so after being in healthcare for so long and being around folks and hearing, the confusion and the places that folks got into and the predicaments people got into, and not fully understanding how to make good decisions or what they needed to know to make good decisions, we started researching it, and we came up with, we felt like this would be a great way for us to use our skills, be able to support our communities and then individuals by being an independent patient advocate. So we did get board certified. I will just tell you, there is a board certification for patient advocates. So if you're ever in the hunt for a patient advocate, I would say that would be one of the first things you look for is board certified patient advocate, because those folks have been through some kind of a vetting process, like a certification, and then it is, I was just checking to see if that was mine. It's the same sound. So we did get board certified at that time, and I'm also certified as a nurse executive. So I have 2 board certifications, and I do healthcare executive consulting as well. But we started this independent patient advocate because, as you know, our aging population, right? So, and plus, David and I both have aging parents. So we started getting into the aging with our parents process and started to realize, so we would say, how do people understand how to navigate this stuff when I'm a nurse and you're a respiratory therapist and we're struggling? So how does the regular layperson figure out how to, what's next, where do I go, what do I do, and that kind of thing. So that was kind of how we started. And when we talk about patient advocate, other people will use the term healthcare advocate, they'll use, but I just kind of stick with patient advocate just because that's probably the nurse in me, but it's basically that could be anyone. So when we talk to you about independent patient advocacy, like you could really have a family member that could be your patient advocate, that could be your advocate, right? And everybody should have someone that is their person to be able to jump in and help them with any kind of decision making or any kind of support that they need. And So I put together this little presentation. It's in your package. You guys can look it through it, and we can certainly put it on online. But it's really just very basic. Do you need one? Dan? Here you go.
Thank you very much. And she needs one.
Do one more.
Oh, one more. But, and I'm just gonna kind of briefly go over some of this stuff as we go, and I'll use some examples as we go through, so that'll make things a little bit. But it's basically, a patient advocate is someone that focuses on, helping individuals go through their healthcare experiences, and it should be someone that is a guide for you and a support system for you, someone that's able to educate and help you with your decision making so that you, the individual, are able to make the best decision possible. Patient advocates and advocates never make the decision for you. They are just there to support you through that. And it should always be an individual that is focused on your individual needs, and that is one thing that David and I work hard and pride ourselves on in our business, is that we always tell folks that your plan of care is your plan of care. It's what you want, and there's never a wrong answer, and there's, it is what you want for your future, and it's how you want to handle your health care. And that's how any of your health should be, really. Like when you go to a physician, your primary care, your specialist, it should always revolve around you. And I talk a lot of times to individuals when I go to groups and talk. When I was a nurse and was in operations and management and did all that, my philosophy always was any patient, any place, anytime. So that would be any individual that needs care or needs something, we should, as a healthcare system, be able to adapt to meet that individual person. And I feel like that's still true even as an independent patient advocate and in the community, because that's how we want our communities to grow and our individuals to feel like whatever stage of life you're going through, your healthcare system should be able to adapt to what it is that you need. Which I know that's probably a very different way to talk about healthcare than what you're used to, because you're trying to figure out the system and figure out where the niches are, right, and how to make it work. But really, that's what healthcare is all about, because it's a basic need. So I have a little success story in there. I'm not going to read through that, but that is Miss Abby is an individual client of ours. She actually moved out of the area and she went to live near her daughter, but we use her story a lot. And I'll just give you an example of how we helped her. So her and her husband at the time, he had Parkinson's and was struggling. She had been taking care of him at home and then needed to figure out how to do the next transition. And she actually had a home care agency that she was using somewhat, but it was still very, very overwhelming to figure out how to do. So we got referred to her through common folks, and we went in, and so then it was time to sit with her and figure out what her husband would want. And then we got into more of the intimate details in talking about what her insurance was, if she had long-term care insurance, the price of what long-term care was going to cost, what Medicare covered, what things didn't cover. And we were able to help transition her husband, and then her comfortably understanding what it was she needed to do next. And he had some insurance issues with his Medicare and how he had initially signed up, so that became a little bit hard for her, so we worked through all that. So that's just, and I'm giving you that little story just so you know that was one, that's just one example of how we do it, and it's not always a very straightforward, hey, what do you do? So we like to talk about kind of the situations and the scenarios that we've done. Miss Abby's husband did pass away, and then, like I said, she did move closer to be with her daughter, but she was able to, with our help and with us understanding what her husband wanted, to give him the best quality of life and move through the things and be able to understand and feel good when the end did come about what she had done and how things had worked out. So, and that was what she wanted. And I'll just give you one other key in that piece, was that they did not want to be a burden on their children. They had 2 girls. So she relied on us, me, a lot to be able to help her over those little crisis pieces, so that when she went to talk to her children, she would have things under control at that point, so her kids felt more comfortable and felt at peace with what their parents were doing, because they lived 4 hours away. One lived in Virginia, one lived in Maine. So that was kind of how we helped her.
Marilyn, was the husband involved in all of these conversations?
Well, he was, yes, somewhat, but his Parkinson's had advanced a fair bit. So when I came on board, he had been admitted to the hospital. He had, some sepsis, that kind of thing. But we still had very good conversations. But he had made his wishes very clear to his wife, so that we were very comfortable. I was very comfortable in working with her and him, but we always kept our conversations with him to a minimum. A lot of times we visited together, but her and I would talk off, and then we would go back to him, if that makes sense, because it was, so she had the full responsibility at that time. So I know people, like, how many of you here heard about us before? There's a few. But not a lot, we're still, even though we've had our doors kind of open for almost 5 years, there's still a lot of folks that don't really know about us here in the county, and there's folks that just don't know about independent patient advocates or, healthcare advocates in themselves. The industry started growing probably about 15 years ago with the prediction that it would grow about 100 to 150% each year for the next 15 to 20 years. And with that comes the statistics for aging, right? So I don't know, I read the little Retired Investor, which was a great little article, but just to make, kind of tie that in together, right now we have over 11,000 people each day that turn the age of 65 in the US. If that gives you got over 4 million this year that'll turn 65, and that's predicted at least till 2027. That is going to be, so we're in the biggest boomer 65 rush right now. So where we come in, why do people need a patient advocate? How do they find us? That kind of thing. And usually typically I like to tell people there's 5 reasons that people usually find us. There's usually a reason they're in the healthcare system, and there's something that happened in the healthcare system that has caused them stress, and they're looking for a patient advocate. Like, they either feel like they've been mistreated, they've had some misdiagnosis, they've had they need a second opinion, they need their medical records reviewed. Like, I'll just tell you, I got a phone call probably 4 weeks ago now with an individual in eastern North Carolina that she was advocating for her husband, who had been in a hospital in the Wilmington area, and they were receiving very poor care, in her opinion, and she was struggling, and from what she had told me, her husband was really not doing well. So she had called to say, how can I advocate for him? Like, I have no idea what I need to do, but he's not getting his treatments, and when she told me, I was like, this man sounds really sick, and he was really sick. So I gave her some, right then in our 20-minute consultation, I gave her the way to find the numbers in that hospital to get immediate attention. The corporate compliance line, some other agencies to be able to contact to get urgent, intervention if needed, and then also an alternative to how can I get out of this hospital and get somewhere else.
What's your geographic footprint? How far can you go?
So we are locally, we try to keep it, so I do have clients in Wilmington area and a little bit south of Wilmington and some in Virginia, but we also have clients all across the country. So if we can do things by video and phone, I will do things by video and phone. If it's local and like you want someone boots on the ground, then we try to keep it, from Raleigh to like south of us. So we try to do mostly eastern North Carolina. But I'm like, we're individual, we're independent, we don't work for anybody else. So if you called me and said, I want to pay for your travel, I want you to come to my home, I want you to do this, then most likely I'm going to go wherever you need me, right? Because that's what, if you want me, then I'm going to, most likely we try to. That's why I said I went to Virginia for a client. I drove 12 hours, but her boys were adamant. They needed me to go. They needed me to be able to sit with mom. So they paid my travel. I went, I spent 5 hours with mom and the son that was the caregiver and got through. I mean, we worked a lot that day and then came back that night. But that was the only trip I made to there to see them, you know. So we can. That's
Out of
kinda.
curiosity, what was the conclusion? What did you do for them?
So this lady, she had 4 boys and she was single, and they were all in the construction or different trade industries, had no health care. The youngest actually became her caregiver. And then it was, I don't know if I'm doing this right for mom, I don't know, you know, and I was trying to help them do things over video and phone, like set up patient portals, go through bills and stuff, so they had a good, because she had been hospitalized and was discharged, and they had a pretty good plan of action, like what they wanted to achieve and where they wanted to go, and she was in PT and OT, but the big picture was missing. You know what I mean? Like they just weren't sure, are we doing everything right for mom? We're a bunch of guys here trying to figure it out, and we
Was she
don't
living
know.
on her own somewhere?
Pardon?
She was living on her own?
Yes, she was. She was young, like late 50s. So it was not a good, right? So now, you know, you're trying to give mom the best quality of life, and so long and short, so when I went, that's what I said, when I get there, let's do the biggest bang for my buck, right? Let's get all your medical bills together, have all your medicines together, have all your PT, OT stuff together, and then I will sit with mom and the youngest son, and we will spend a day, we will go through everything so they know which bills were urgent, what ones they needed to look at to try to strategize. They were looking at Medicaid applications because of her disability, so I was able to go through and then I was able to help the son get all of the patient portals set up, and I was able to give him all the questions and answers of the information that he needed to be able to obtain from those portals. Does that make sense? So that's why I was saying, like, every case is a little individual, right? So that was that one, and there another that was and the other piece of that was she had some mistreatments and misdiagnosis in the beginning, so there was also the lawsuit piece. So we are not legal, we're not lawyers, we don't do that, but David and I both can be medical experts because of our expertise and our years of experience. So then I also reviewed some of the charting stuff and gave them a plan of action in things they could take out of that to use to be able to either take to an attorney or take to the hospital to be able to sit with a one-on-one. So there's some of that as well that we do. So that's that's kind of like one of the big reasons people look for us. You know, they get on the internet a lot of times, or they're asking around, hey, do you know somebody that can help me? And this is kind of where, because a lot of times if you're in the hospital or you're in the system, you don't want to go to your provider, you don't want to go to that person because you don't want any retaliation, right? Because you're kind of very vulnerable to those people in your care, and you want to make sure. So a lot of times people start asking and looking outside of that system to see. I think old time would be, do I need to get a lawyer? Do I need to look for a legal? Like, what is wrong? But I think when people start to search, then it's the patient advocate pieces that kind of pop up, because we're able to get them through a crisis then. And the second biggest thing that brings people to find us, look for us, is they have personal barriers, okay? They just get diagnosed with a brand new illness, cancer, Parkinson's, dementia, you know, those big heart failure, heart disease, those big diseases that are going to change your quality of life and are going to change your quantity, really, and where you most people are, first thing they're like, I wanna stay in my home, I wanna stay in my home, I wanna stay in my home, right? But if you can't, then what are my next options and when do I need to start looking at that? And that can be very, very difficult for folks, especially when you're tangled up in it and you're trying to, you know, just be the caregiver or be, you know, just keeping yourself alive. I'll just, and we use our family a lot as examples too, so David's dad had end-stage renal disease. He was a Vietnam veteran with Agent Orange exposure, became fully diabetic, fully disabled, and then ended up on dialysis. And so he's a veteran, he's on Medicare, he's got supplemental, and then we're trying to navigate, but he did not want to go into long-term care or assisted living. He wanted to stay home. So it was always trying to be as preventative as we could and figure out what the benefits were, but that was nothing that he could do on his own. Absolutely nothing. He was, you know, he had an 8th grade education from school. His health literacy was probably on a 5th grade level. He worked hard all of his life. He had a little bit of money in the bank, but this was just not anything that he could do, and he was single. He had no spouse. So David and I became his lifeline, right? To be able to keep him as independent as possible. So that's the other, and I give that example as, so those are like the personal barriers. Those are the things that individual people, that's how they start to look and why they look for us. Cause they're just.
How did he find you? I mean, if he's by himself and he's struggling with all of this, it's gotta be overwhelming. How did
So
he get
here,
you?
I will just hit, hospital's pretty good about referring folks to us. Their discharge planners are. We have some primary care here that are familiar with us that we get referrals from, but we get a lot through word of mouth. Like a lot of our people that have had us as their advocate, they a lot of times are very open and talk a lot about us, but we try to stay, like we have our website, we try to keep up with, you know, social media, we try to do, you know, presentations like this, we try to, but you know, we're just a small business, so the marketing piece, like I don't have the hundreds of thousands of dollars to spend, you know, because once you get into that, it's really, so those are, but we do have, when I pull my statistics, about a third of our folks find us on the internet. And then there's about a third that are word of mouth. And then we have a referral base. You know, we've got a couple financial advisors here in the area that send folks to us all the time. It's like when people finally realize the value we bring to people's lives and the, you know, and the support we can give not only their clients and their patients, but their whole practice, then usually they're pretty, you know, they're pretty on board, and we usually get a fair amount of referrals. And usually, and I just statistically, and that's why I'm telling you, because I'm still learning about the whole independent patient advocate piece with everybody else, but out of every third phone call I get, we usually is someone signing a contract with us, and we go into care. So that's kind of a lot of ways that our business runs. And we give a free consultation to everybody. So I tell folks that all the time, like, it doesn't matter if you can pay or if you can't pay us, just if somebody needs a referral, give them our name to do a referral. I have access sometimes to I have a great guy right now that is, he's actually a reporter / works somewhere in the, I don't even know where he works in the federal government, but somewhere as an advocate, but he has a nonprofit and he actually filters folks to me and he pays for them. And then we have access to another group that their focus is people who are in financial burden from insurance, medical debt. They will filter money to us to pay. And now we're in the process of, Medicare has just approved a community health worker, which is a slice of what we do, but there is hope that we actually may be able to charge for some of our service through Medicare and eventually through Medicaid. Of course, that'll be, you know, a slice and a piece, but it is coming. I hope. We keep our fingers crossed. And then just to kind of tie up, and then we can kind of answer, I can answer questions. Emotional barriers is another way people find us. Like, people are trying to be the best caregiver they can be. Folks are, you know, trying to make sure they do everything for mom that they possibly can, but then they get health issues themselves. Or they're like David and I, you know, we have aging parents, but we have a 20-year-old and a 16-year-old and 2 full-time jobs, right? So when mom or dad gets sick, then I'm trying to figure out, like, I can't take another day off work. I can't go to Chapel Hill this time. Like, how do we figure out so that's kind of what we were like, if we knew someone that we could trust, that we could pay to go to a doctor's appointment with them, then we would. So anyway, so emotional barriers are another reason why people look for us. They need support to be able to get through it. And I think that, and then the other big one is financial barriers. So we do, in this past year, and I don't have this on my website, but I'm going to tell you all here, and I hope that one day I'll get there and get it up there. So last year in 2023, we saved clients through medical review over $400,000 by going through their medical bills and helping them. It's probably, the total is probably going to even be more than that. I just, through this gentleman I was telling you, this media guy, Marshall Allen, I've been helping a veteran in Ohio go through his stuff. And he just texted me last week. He was being stuck with, it looked like it could potentially be $500,000 worth of bills because Blue Cross Blue Shield had pulled back all of his claims. When we got into it, it was like $50,000. Anyway, and I've been working with him since April of 2023. So right now we're up to, he said, right now you've got $80,000 worth of bills. My chiropractor is about to come in, so every bill that I've faced in the year before that, he said, I think that you've been able to help me flip, and we've got every bit of it repaid by TRICARE for him. So that is another big, like, another piece.
TRICARE, what's that?
So TRICARE is the veteran coverage.
Oh.
And so he's I think he's 100% disabled from the VA as well. And their insurance pieces, but a lot of times people will get secondary coverage even though you're a veteran because they don't always cover all the stuff. So what happened to him was he had this secondary coverage and it was through a family thing. Anyway, long and short, Blue Cross Blue Shield gave him coverage for 1.5 years longer than they were supposed to. So when they realized they had screwed up, they pulled back 500 claims of his, which were almost $500,000 in claims. So we thought we could never get the EOBs from Blue Cross Blue Shield. And then anyway, long and short, when I was able to work, I mean, and I got stacks of stuff sent from him that he was just getting bills and bills and bills and bills. Now, and this is one of our veterans that, you know, he has PTSD, he struggles, he's on his own, and so finally, that was, I said, 2 weeks ago, he finally sent me and said, Marilyn, I think we got it all. Like, I think TRICARE is reimbursing now to the hospital what Blue Cross Blue Shield pulled back. So we were up to 80, and he wasn't supposed to get his chiropractor bills paid, and I was like, don't give up, you know. It's like running a marathon, right? You have to just keep going and keep going. You have to keep. So I said, go back to your primary care and ask them if they'll approve a new chiropractor, and if they approve the new chiropractor, then maybe we can fight to get the old chiropractor bills paid. So when he called back to TRICARE, that was said 2 weeks ago, they were actually paying his full chiropractor bills too. So he said, I think I'm going to get 100% of it paid back. And you can go on our website and our social media. There's a lady in Wilmington. We actually were interviewed by the news in Wilmington for her. She was actually a pullback claims from Blue Cross Blue Shield as well of North Carolina. She had $50,000 billed. She was a disabled lady that got her disability approved. She worked with a lawyer, got disability approved. Her disability got backdated, when it got backdated, Medicare got backdated, Blue Cross Blue Shield pulled back. Hers was, I think it was 294 claims. She had $50,000 worth of debt. Boom, just like that. Disabled. This lady has chronic migraine, like can't focus enough, is alone, taking care of her 90-something-year-old mother, and was expected to figure out. So I did some help. She paid me, and these stories are everywhere, so she knows she's good for us to talk about it. She paid me what she could, and then I did pro bono what I could, and then Marshall helped pay for some, and we got out of her over 50,000. We got over 40,000 of it back, and got Medicare to cover most of it. She still has some, and we're still actually fighting some of that, but so we do those pieces too. So that's where the big numbers come in, right? Like we help people work, and those are not like overnight. Like we're working with a lady right now in Florida, and she had a insurance that her and her family got, and she thought she was getting an Affordable Care Act insurance, but actually it was a different one where they say they do not uphold, like they do not cover pre-existing conditions. She had a CAT scan one day and her insurance kicked in the next day, but that CAT scan showed two carotid aneurysms. 40-something years old with two carotid aneurysms, no symptoms, but the insurance is claiming that as a pre-existing condition, and they niched all of her. So she has $50,000 in debt for two urgent carotid surgeries. So we're in the process with the state of Florida, with their Department of Insurance and the hospital, and trying to help get that covered for her. So that's a little bit. So there's some stories. You know, I could talk about what we do in stories forever, but because if you've figured out yet, we're very passionate about the whole trying to help people navigate through this system and get what you can out of it and have the best quality of life and the best quantity of life possible. And some patient advocates, and if you look and you research anything about independent patient advocates, they will specialize, and you'll have some that deal only with health insurance, you'll have some folks that deal only with cancer patients, you'll have some folks that deal with autoimmune disorders. So they've kind of taken either it's a personal experience or the area that they worked in healthcare, and then they do that. But David and I have been we've tried our best to stay very open, because we have a lot of experience from two health professions together, to keep it so that so anybody can call us about anything, and we hope that we can at least be able to help or navigate, help someone to find their best resource possible, and not specialize, but leave it in a, open area.
One thing, there are a lot of folks, and we're probably an example of one of them, that when we look to go somewhere, we're gonna move closer to one of our children who live out of this state. So what we would wanna know is how our health care would transfer.
Right.
And
So we helped the lady that moved from New Bern to Virginia to move closer to her daughter, same thing. So there's and what we offer our clients, and what I did for her and her husband had been our clients, so I already kind of knew, I did a checklist for them, because the daughter was kind of going to take over the advocacy piece, but so we went through the checklist of finding a new primary care, finding a new cardiologist, so then I helped them figure out, who had the best rating, plus they wanted proximity, she didn't want to drive too far, where she was living, where her daughter was, because they actually went to an independent living facility in Virginia. They've left their home in New Bern to go there. And then the health insurance piece.
Right.
So I reviewed their health insurance piece, and I did review their health insurance piece as soon as we took them as clients, and I said, do not change your health insurance. Do not change your health insurance. If you can afford it, do not change it. Do not get a Medicare Advantage plan. Stay with your Medicare and your supplemental. You have a good plan, you'll be fine, don't change it. And she said, I said, just hang up. Don't take any phone calls from anybody, don't do anything, just keep your health insurance just the way it is and you'll be fine. So that's what a lot of folks don't realize, and if you are into an Advantage plan, you get into a lot of restrictions. And then not such a great coverage a lot of times. There are a lot of, we have some federal lobbyists that are getting up against it. We have some state lobbyists here that are trying to push, but we're kind of behind the 8 ball, right? Because we kind of let these Medicare Advantage folks come in and they've kind of ruled the roost on what they want to do. And now we're realizing there are some really bad missteps in there and folks are not getting the coverage that they need. So and I'll just give you one example in that. Are you guys good with me talking about Medicare Advantage? Yeah, okay. So when it comes to rehab, okay, everybody knows someone breaks, knee replacement, or you break a hip, or you have a really bad UTI and you get septic, like a lot of folks over the age of 65 will need what they call subacute rehab or long-term care with rehab for those 21 days that Medicare covers, okay? So when you have Medicare and the supplemental insurance, like you say, I've got Medicare A and B, and then I've got a Medigap, which is Blue Cross Blue Shield, right? So you give them your red, white, blue card, and you give them your Blue Cross Blue Shield card. That is going to give you the maximum coverage that you can get for subacute rehab. And that's the best, and that's what long-term facilities want to see. So those folks that have Humana or Aetna or Blue Cross and Blue Shield Advantage plans, what they have is they just pretty much present one card. You do have your red, white, and blue, but it's this, because now it's all controlled by the commercial insurance. What's happening is a lot of these folks, a lot of these commercial insurances are denying everybody that 21-day stay. Right off the bat, they just deny everybody. And it becomes a very long process. A lot of times hospitals have to reappeal, or you have to go through hoops to get that coverage to be able to get to that 21-day coverage in rehab. And some of these Advantage plans, what they actually have is they have co-pays built in for those days, and they have co-pays built in for the hospital days. So you might think you're getting a great deal on insurance because you got a low monthly payment, but if you're not well and you get sick, then you rack up a chunk of change pretty swiftly. But the hardest part, and that's not so bad, because you know what, you got an Advantage plan, you take the chance, right? If I get sick, well then I gotta pay $150 a day for being in the hospital, then I'll pay it. But I haven't been in the hospital in the last 5 years, so I might be good. The problem is that if you end up in the hospital and you need to go to rehab, then that's where the hiccup comes in, right? Because you're being denied that coverage because some of these commercial plans are they're just playing games. I mean, I'm not an expert, but I'm just saying from experience, and I see it, like, they like to deny stuff because when they deny stuff, almost 50% of people that get denied don't even appeal it, right? So they're making money. So that would be, and I talk to folks about that because it really can be just a bad disservice to you as you age. And if you can afford to keep that, Medicare A and B and that supplemental, like I tell a lot of people that are enrolling now, they've been enrolling in that G, which has a little bit higher deductible, but it's not as expensive as like some of the other, I think it's C and F, some of the ones that have the supplementals that have a little more it's just you have to pay a bigger deductible, but you actually end up with the same coverage. And those are called Gs, and they've been pretty popular last few years because healthier people then, instead of getting the Advantage, they're doing that, and they're like, I'll just take the chance to pay, if I have to pay $1,000 extra in a deductible, not so bad, but I'm not gonna get denied long-term care if I need to go there for 21 days. And some folks had, like, I'll just say, David's dad was a veteran, but he also had Medicare and he had a supplemental, and we kept him because he almost switched to an Advantage plan a couple years ago. He did get, someone called him and he thought it was great, and he called me and I was like, oh no, we can't do that.
Can people switch back?
So you have a limited amount of time that you can flip back. And then sometimes, and that gets, and I'm not 100% on all of it. I usually will refer people to a ship advisor then for North Carolina to talk about that, because, you know, sometimes people are individual and I don't always know exactly what individual plans are. But you can flip within the first year without any penalties, but then after that it gets tricky. But I've had some clients that needed to go on Medicaid, so we were able to get them flipped back without a supplemental and then Medicaid. See what I'm saying? So sometimes it's like it's a circumstance individual piece. So.
I've been a ship volunteer,
Uh-huh.
and you can switch back during open season,
Okay.
Okay.
each year during
Oh,
open
oh,
season.
okay.
But then isn't it harder with the supplemental because they look at some of it for pre-existing conditions?
I think that's what it is. Within the first year, you can go back, if I remember.
Without the pre-existing.
Without and they will not do anything. If you had a different program and you decide you wanna go back to your.
Because I've had a couple clients that could not get supplemental because they called it a pre-existing and we had to just go with Medicare A and B and no supplemental.
Yeah, but I don't think you can have it, I think you can switch back within a year, less than a year.
Yes, and no
Less than a
penalty.
year, and you can switch back without having to have a health review or any of that
Right.
stuff, if I remember correctly.
Yeah, I
which
think that's,
my
and I
understanding.
think that's where it comes, because the individual that switched back with one of my other clients, we were trying to get her on Medicaid to get her into long-term care, and we were going through the Medicaid spin down and all that stuff, and, we got her back, but we could not get a supplemental for her. But it was okay, cause we had exhausted her funds, so Medicaid had to pick up anyway. You know what I mean? So, and then I had another client that had not picked up his Medicare B, nor his Medicare D. So we had to get penalties paid, and then we had to go on an Advantage plan because no supplemental would pick him up. Because he had pre-existing conditions.
Right.
I know it takes an act of Congress sometimes to get that.
It
straightened
does, but
out.
I'm just telling you, your ship is the way, and that's what like I said, I'm not an expert. I don't claim to be. I mean, we help a lot of individuals with stuff, but a lot of times what I'm doing is I'm calling that ship and saying, hey, I got this client that I've got A, B, and C. Like, where do I need to go next? So I've learned a lot, but I'm not. But often in my consultations, like the 20 minutes, if they're coming with something that I know ship can handle, I send them right to ship. I'm like, just go right to, you know, and you don't like use me for something else,
Yeah.
right? And call ship to get what you need from an insurance standpoint. So, yeah. So,
Can you describe the process that you use to argue a bill with an insurance company? So, where do you start? If you get rejected, how do you go to the next level?
So a lot of times when people come to us, and sometimes we do these little, you know, videos and we talk about people about health insurance, you know, the basics of it. You know, we tell folks all the time when you get a bill, review your bill, don't pay your bill until you get your EOB from your insurance. So make sure you get that Medicare EOB if you're on Medicare. And then we tell folks, if you question anything, get an itemized bill from the institution and make sure. Like that's just standard. Anybody should tell you.
Do you often find it's, some bills are misbilled because of coding errors?
So I think statistics say about 90% of medical bills have errors.
Yeah.
Yeah, I mean,
So,
That's
yes,
more than 5%.
that is
I think
some kind of an
people that do
error,
these
right?
codings are
So that's what I'm
not-
telling you, like
Eighth grade
this,
education.
Yes.
we had this man come to us last year, so he was taking care of his brother, who was he became his, guardian, okay? And he said, Marilyn, I have $350,000 worth of medical bills. And I just sold my brother's house and I have this amount of money and he's gotta go in assisted living, so you need help getting assisted living. How much money do I pay? Like, where do I said, okay, so send me what you got. So he sent me what he got. So right off the bat, I looked at his bills, $197,000. I said, you don't need to pay either one of these bills. And I said, you were billed incorrectly. And he said, how do you know? I said, because your brother's on dialysis and either the VA or Medicare pays 100% dialysis. So you should not have these bills. He says, so I don't pay, I said, no, you do not pay those bills. That is $200,000, we can take off that 350 right now. And he said, well, you're already worth everybody your money. And I said, I am, right? Like, but he was so sweet. But this was a retired dean from a university, I will tell you. So it ain't about, like, it got nothing to do with your education. This is about difficult stuff. So I said, here's what you can do with those, take those 4 bills right off the bat, call them, make sure they have your brother's Medicare number, make sure they have his VA number. They will know which one to bill. Tell them to bill Medicare first if they do not. And you should not see another bill from these, and put them right there in the paid, right? Your notes on there and be done. He said, okay. So that was that. So that, like, so it depends on what we get, but the basics would be, we tell every individual to, when you get your bill, do not pay it until you get your EOB, until you are comfortable with that EOB, that the charges are correct. And if not, you get an itemized bill. You let your provider know you're not paying it until you review all that, and there's nothing they can do about it. So coming up to another thing about bills, I'll tell you another. So I just helped the lady in Arizona. She was an advocate for her brother, who he had a surgery in December and a surgery in February. So you know what that means, right? You have a deductible to pay for 23 and a deductible to pay, well, it was 22 and 23, because we were looking back at the past. So when he went in 23 to have his surgery, they would not do his surgery until he paid his deductible, which was almost $7,000. He needed open heart surgery. They never came out flat right and said we won't do it, but the billing said that, you know, if you leave here and don't pay, we can't guarantee your surgery will be done, which is an absolute no-no. Like, people don't, you can't do that and tell somebody your life, if you don't pay your bill, we're not going to do your surgery. And most insurances, which I didn't know this till the fall, I learned this the fall, most insurances have that in their contract. They actually have that. You cannot require deductibles up front from our clients. And they actually have it written in most of their. So what happened was he paid that money, and then it just became a nightmare because there was other charges that were in, and his deductible should have been applied to other things, and then there was a year before, but I'll give you a tip on that. So because he didn't pay his 2022 deductible up front, his sister let it go to collections, and then she actually was able to finagle it to get it down to 50%. She only paid 50%. So there was a little, whether people feel comfortable to do that or not, but there are a lot of folks that do that when they have those huge deductibles, because you think he had to dish out $14,000 between December and March, which, like, he didn't have it anyway. But, you know, that's what she said, like, he didn't have it to pay. Like, he paid that one that he had to have for a surgery because he had to pay it. They said they weren't going to do his surgery, but she was able to finagle and get 50% off of his bill from the one before. That was a lot, like, that was a lot of money for them to have to pay up front. So that's a little, if it does go to collections, you can negotiate.
I wanted to ask you something, as far as the $200,000, because the person was misbilled, who had to handle that? 'Cause if
The
you
brother.
don't-
The
Okay.
brother, he was the guardian, so he had to. Now I could have done that for him, but he would have had to go and just add me to the HIPAA. You know what I mean? Like, kind of just call
You
them
could
and
do
say,
healthcare.
I could do that for him. So my lady that's in Florida that we're dealing with the pre-existing conditions, she's pretty savvy. So usually I just guide her. But when she gets frustrated and she's not sure, so like yesterday she emailed me and said, I just want to let you know that I did put you on Brandon Hospital, and I may need you to call them to make sure they're actually doing what they're supposed to do, because I don't think I can talk to them anymore. You know what I mean? Like, it was that, like, yeah, it really, people get so frustrated. But then when I call them and I say, hey, I'm, Marilyn, I'm Whitley Patient Advocates, I'm working with so-and-so, they're my client, you often get a little different response. And then often I'll
Fair
just,
guy.
yeah, I just go, and we tell people that all the time too, like, I know it's, you know, it's hard to think that because you have a patient advocate, sometimes that goes a little further and you have a little more security if your loved one's in long-term care or in assisted living or in the hospital, but it really does most of the time mean that you have a little flag, or, you know, people sometimes will say they felt like the staff were on their P's and Q's after, once they know you were with us, because you're a nurse and you know, and you know, they pay attention, so sometimes it's just our name that gives folks, you know, a little bit of security, so, but insurance, we could talk about insurance all day,
Yeah.
so.
So how do you get paid?
So individuals, most folks pay us just like
So
we
there's
do a lawyer.
monthly fee that you.
So we try to do everything individually based, and I try to do everything for families on the service as opposed to an hourly rate. So if I'm gonna be doing my nurse executive and I'm into a big corporate and I'm doing, then I usually will do like a consulting and I'll do like an hourly rate and do everything. But if I'm gonna sit down with a family and we're gonna figure out, you know, I can pretty much judge how much time it's gonna take me, you know, and being able to get a good big picture. So we usually try to do with individuals that are local and we're going to go and spend time with them and be boots on the ground for them. We usually will do a setup fee to start, and right now that runs about $350 to $500 depending on, you know, what we have to do. And then after that, we do everything by the service. So you might only need a setup, and you might only need to know, hey, I got my stuff in order. I'm all right. I'm good. I know what thank you, Lord. Like I'm good. I got this. I'm doing all right. And Marilyn told me I got it, and I don't have any more questions. And we do the setup, and then you say, okay, I just need you to be kind of there if I need you, and we do that. And then we call that like you're kind of in a partnership with us, and then it's a fee for service, right? As we go, we do it. Or we set it up, and then we come up with a plan of action, and then you say, we have 5 things that need to be done. Like if it's, I know I need home care, I know I need a housekeeper, I know I need some transportation issues, I know I need to see some specialists, I need some coordination with my appointments, I need some help with a caregiver. So I know we got some work to do. Like it's not gonna be, but I can give it to you, and if you have a person, that's your person that can accomplish that for you, then that's it. But if you don't, and you say, Marilyn, I can do A and B, but I cannot do the rest of it, and I don't have anybody, so I need you to help me, and I need you to be with me, and I need you and your husband to be able to. I said, okay, so then we work on what the services and the fees will be, and if it'll be a monthly, or if it'll be, you know, a long-term or short-term. I will just say you know, the maximum that we've, we did a husband and wife, and it was a pretty it was a hard case. Like I was there almost every other day, if not every day. And theirs were like, you know, $3,000 or $4,000 a month. But that is like a lot. We organized 24/7 care. We were in and out of the hospital. We were, you know, it was just a lot. And and that was the most extreme. But you're talking like, a husband and wife that had crisis at the same time, and they had 2 boys, and they were at a state. So we had to get them in, and we had to get, you know, and end of life, and also estate. So we do help with that too. Like we're not again legal, but I usually will know enough to be able to help point them in direction, or they may need papers faxed, or you know, will give me their will and their death certificate, and then I'll disperse to things that they need to get done, that kind of stuff. But for the most part, you know, individually.
Thank you, I have an obligation.
Okay.
Thank
It was
you so
nice to
much.
meet you.
Yep.
You know, we don't feel like we're, you know, overly, sometimes folks could pay $750 a month, you know, for a few months, and sometimes it's, you know, $1,000, but again, it all depends on, and that's why I said we don't do an hourly rate. It all depends on the service, and then where they're at and what they need. but sometimes like just the check, we'll just say like just the check. I have a couple clients that I do, I have one individual I do once a week medicine check for him, and I'm usually will do, and those are usually quick visits, and his is usually around $300 a month. And sometimes there's a doctor's appointment in there that I go, a local one, like I'll go to the VA or cardiology or something here with him. And then I have another client that we usually just meet once a month, and we have certain things that we do for him, and some of that's like care coordination, physician, how he's doing medications, bill pay, just making sure things are, you know, checking on all of it. And his runs between $175 and $250 a month. So, and it's usually a phone call or two, like a week or something like that. So,
Marilyn, it's my understanding that you also supply people for these services, that you interview and then
I can.
designate to do those cases.
it all depends on what you want. So we've had individuals that, we had one of our very first clients was a husband and wife, and their girls were in Western North Carolina and South Carolina. And they just were so we came in, mom had a health crisis, and we actually did interview healthcare agent, like I called all the healthcare agencies, we got some local caregivers, we got some agency caregivers. I did the interviews with them, and I kind of did like an overview first and kind of narrowed it down so they just had minimal stuff to do, right? But they did not want their girls to come do that. They wanted me to do it. So I would do all that, and then I would conference with the girls. What mom and dad, I mean, they trust us, like this is so he was like, no, you talk to them, because they think I'm, you know, crazy half the time, and I'm like, you're not, you're fine, you're just, you know what I mean? It was just, and it wasn't a bad relationship with them at all. It was just a stressful, because mom had gotten diagnosed newly with cancer, dad had health, you know, and they just wanted to be independent. So whatever I could do for them at that time, but that was like a 2 months that we had intense, and then after that, it was, you know, things were okay. So.
Do you ever advocate for hospitals to get properly paid by the insurance companies?
So
After you figured out your
I
patient's bill?
I can,
Okay.
and I do, because in turn, we actually do that. So when I get the denial, you know, if I get one, we actually did that one locally here for somebody that got denied. And they actually didn't owe anything because it was on the hospital end, but we actually, so that client actually paid me, and I actually worked with the hospital to try and get the hospital the money. So she would, because she felt bad, because she kept seeing, and plus she was scared that this $50,000 bill was gonna come my way, right? So we actually got it in writing that the bill was not gonna come her way. And it was the hospital glitch, but we did appeal on behalf of the hospital to try to get their money. So.
Well, I was gonna say, I get the feeling you oversimplify some of the complexities of dealing with all these agencies that you have to deal with. Because what I find of late, and I probably complain too much in that regard, and healthcare might not be as bad as other businesses, but gosh, when someone gets screwed up, to try to unsnarl it, or to get to somebody that has any authority
Oh
or
my
even
gosh.
cares about you, I think just the level, generally speaking, of customer support out there today, represented by the companies that they're part of. But you talk to somebody that doesn't know, really doesn't care, and it's frustrating to say, well, let me talk to your boss. I don't have a boss. Let me talk to, no.
I know.
So it's,
It
I
is.
think, that's what I'm saying, as far as what you do,
Right.
I sense as you oversimplify some, because it's
I could be
aggravating.
doing anything.
It takes a lot of persistence to get to somebody
Yeah.
who listen or will care or has any authority to do anything anyway.
So I've learned a lot about the buttons to push and the numbers to call. And I will tell you, I try to partner with as many people locally as I can. And not that we're feeding each other's pockets, I'm not saying that, but I try to have good relationships with all the home care agencies here, and keep so that I've got a good contact number, so that, you know, when the patient advocate contacts them, because they do know it, and I am a patient advocate, and say, hey, you know, I have a client that's probably going to be looking for some care these days, have you got any availability? And then I have a couple I have a couple that, and one in particular, like if I do text them, I'm pretty much like, if they have something, I'm gonna get it. You know what I mean? Like I build that. That's a part of me trying to build those. But I don't take monetary for it, and that's a part of the being a patient advocate. That's a part of my licensure. Like I don't take referral money from anybody, and none of the patient advocates that are board certified do. It's just something we don't do. So
I think your knowing the language is also, removes
very.
barriers, you know.
So I worked inside the health system, right?
Yes.
So I worked in it in North Carolina, in the United States, and in Canada. So like that lady that called me that her husband was dying from Wilmington and she was worried, and she said, I'm putting him in the car tomorrow morning and I'm going to UNC Chapel Hill. I said, go for it.
Yeah.
I said, put him in the car. Leave tonight if you got to. She said, I'm not going back to that emergency. I said, then don't go back. I said, what's the worst can happen? You'll call
Yeah.
911 on the way. You both agree that's what you want to do, then do it.
Yeah.
Right? But that was all she needed to hear was, but I also said, but here's the number and here's and I will just tell you, so he did pass away. And it's been very hard for her. So I just told, she wants to get some closure. So I'm actually working with her to put together a nice piece, and we're gonna present it to the right people to get some little heads to turn, and she's gonna get some closure and that. But so we do that too. But that's a piece of, like you said, I've been on the teams. I know the trigger points and the words. When you call this one person and say this one word, you're gonna get.
What's the word?
You're gonna
What's
get
the word?
retaliation
We're not
is
paid.
one huge
I'm gonna
word.
sue.
So sue is not. Retaliation in care is huge.
Oh.
So I'm just gonna tell, if you ever call, if you're worried about your loved one getting taken care of, but you say, I'm afraid to say anything to anybody because I'm afraid my loved one won't get the care they need,
Yes.
that is huge in healthcare. That goes way further than a suit. People don't care about the suit. They
They've got
really, like,
insurance.
it just doesn't go, you know what I mean? Because they just think you're just
You're
frustrated and you're just blowing. But if you talk about retaliation, that is a huge in healthcare. It is huge.
Really?
Yes.
What's retaliation?
So if you, and that's why I said, like, you, as a healthcare industry, you cannot withhold care from anybody, right? It's like a bully tactic. It's like in the schools with the kids and people, like teachers not addressing bullying, or, you know, those are huge things right now. So if you were to present to someone on the administrative, and every hospital has a corporate compliance line, but if you were to call there and say, I'm worried about my wife, I'm worried about her care, but I'm afraid to say anything to any of the staff because I feel like they're gonna withhold care if I complain, or she's not gonna get the care she needs because I'm complaining. You have a culture that is not putting the patient first, then that stuff flies.
Gets
It
people's attention.
flies.
Well, and my mother's a great example. Whenever she got poor treatment, whatever that may be, and she was non-ambulatory, she was in a nursing home facility for the last 5 years of her life, every day. That, you know, she had to wear a diaper, so not getting changed frequently enough. And then I said, well, I'm gonna speak to somebody to get this straight. No, please don't do that. Please, they'll make it worse.
Yeah, that's
So-
right. And that's the worst feeling, like, to think that your loved one feels like that they are in a place of care where they're totally vulnerable, but they don't wanna question anything or ask for anything because they're afraid that people are gonna get mad or they're gonna withhold. Like, that's where the lawsuits come in,
Yeah.
right? That is huge when it comes to healthcare. But just saying and I'm able to, and the other one is, having a discharge plan that is safe. So if you say, I do not want to take my mom home right now because I feel like the discharge plan that you've presented is not safe, you can probably appeal your discharge and delay for at least probably another 3 to 5 days, if not longer, and get your stay put on. Because you are saying that you don't have a safe disposition, is what they call it. And that's another hard stop, like hospitals. Well, if the family is saying that, they know enough to know
I'm
that.
surprised, to add on that, and we had a recent experience with someone, because hospitals, it seems, a lot of times, even though they're getting paid, or will get paid, or somehow get paid, that they're kinda in a hurry to discharge somebody to get them out. Why? Because if I can bill you another day, stay here for a while, you know?
Well, some of it is you have to remember, so my husband said this to me when my kids went to school. He said, Marilyn, not all teachers are great. Not all nurses are great.
Right.
Not all staff are great. Like, you get some people in this big corporate, they just don't do a great job, right?
Right.
And they just don't care, and sometimes you get stuck with folks like that, unfortunately. Cause I struggled when my kids went to school, you know what I mean? Cause I was like, they're a teacher, and they're not all good teachers. Just
Right.
like you work with nursing and
So
you
you're
know.
saying they're ushering somebody out of the hospital
So there's
prematurely,
that,
and it's just wrong?
and you kinda have to know where and that's the piece, you don't always know where your rights are, right?
Yeah.
If you have a right to appeal the discharge, if you have a right to, do you even know that that exists? Like, do I even have that option? Yes, you do have that option. So
And I
there,
don't know why, and, well, we went through with what I had or something, I said, well, I'm not going, we haven't finished the rehab we're supposed to do, you know, but they're like in a hurry to get you out, and I don't understand that, especially if you can pay or you.
so I had a client locally that got denied long-term care. And, excuse me, and they had, I will say they had an Advantage plan, they had Humana. And the person called me, she was by herself, single. She said, Marilyn, I was supposed to go to long-term care today, and they just came in and told me my stuff has been denied and I can't go. And I said, well, are they putting an appeal in for you? She said she walked out of the room and never told me anything. And she's like, I can't go home, like, what am I supposed to do? Like, I can't care for myself. And I said, and it was close, we'll just say it was close in Eastern Part. I said, hang on, let me cancel my appointment, I'm on my way. So I canceled my next, and I got to the hospital, and we got on the phone with insurance. And I sat with her and we called, and we got that appeal overturned, and she went to the long-term care the next day.
Good.
So,
But what are the options if the hospital says you're ready to be discharged and you have no one at home to care for you, you don't have a long-term care option?
so you could appeal your discharge right off the bat, right? But again, it comes down to it is your responsibility to have somebody, and if you are competent and able to make your own decisions, like, you're gonna have to come up with a plan, right?
I thought the discharge planner has to assure that there's.
So she's gonna assure that there's a plan, but she ain't gonna check that someone's picking you up, like, so I'll just give you my father-in-law, so he's end-stage renal, right? He's going home, he's after being in, long-term care for 6 weeks, then went in pulmonary edema, went in the hospital, now he's being discharged from the hospital, he's refusing to go back to long-term care, but he's going home. So he's got a walker, he's got a wheelchair, he needs oxygen, he needs transport oxygen, he needs, transportation for the VA, cause he can't drive, all of that.
Yeah.
So she asked him some stuff, he could answer some of it he couldn't. So then she called me, so her verification for transport was me telling her that I had it arranged. He was good to go. Do you see what I'm saying?
I do, but if she didn't have you to call, then what?
So what they would say was to him, you have to tell me that you have a mode of transportation. So he would then tell her that he had a friend that was gonna help him, and that would be it. And she would roll. Because it's hundreds of dollars a day to keep you there, right? So they've got their marching orders.
Yeah.
Whether she feels that's a safe discharge plan or not, she's learned how to word it and write it so that, because she's gotta get you out, and she's getting, or he, whoever the discharge planner is, they're getting pressure from above, like you have a expected day of discharge, you have a expected plan of care, a pathway, like, it's up, you need to roll, like, we need to figure something out. Now, I was all about getting him out of there anyway, so I told her all the words, because he was going come hell or high water. I mean, that was just it, right? So we were trying to get him out, and we had stuff arranged for that day, so I was cool with that. But again, it just depends on, so you can appeal discharge. But then they will do, there are some times where people get in there and they're just staying there
Yeah.
until they can get Medicare approved, Medicaid
Medicaid.
approved, financial pieces, but, you know, if, most times what they try to do is get you to long-term care under that 21-day window with Medicare if you have Medicare. That's always their goal, if they can do that, because that's a quick, you know, there's hardly a delay. If you don't have family, if you have family, what they should be doing is working on a discharge plan as soon as you roll in the door, and they're gonna, you know, and they just want those visual and, you know, and the cues and the words that they need to have to be able to secure the plan. Because some people lie, you know, some people lie and tell them they have, you know, my father-in-law said he had someone staying with him. I'm like, he don't have anybody staying with him, he lives alone. And his friend lives 2 miles up the road, you know, so some people don't, they'll tell you, they're ready to go home, they're going home, they tell you whatever, and then they're back in the ear, you know, 5 days later, but, so there is that, so they have some accountability to it, but really, you know, a lot of it then falls into the, you know, the home health agency that they refer you to, and some of the other pieces, but you just think about it, like, you're being discharged and you're being referred to home health right now, it could be 10 days before you see a home health nurse. Like, because they're short-staffed, plus they have to work you in, and then you have to see the home health nurse before you can see PT and OT. So you might have been on a rehab plan every day getting rehab, and then you could go home and have to wait 5, 7, 8 days before you actually get PT again. So it's not, like, our system is not the, you know, yeah, it is broken. Yeah. Any other questions? Can I answer?
One question I have, is Canada ahead of us or behind us in terms of healthcare?
So I think some of it depends on where you live in
But I
that.
live north, right?
Some of it depends on where you live, I will tell you that. Like, I lived in Newfoundland, and I actually went back there and worked from 14 to 17. And they have a very broken system, I will tell you that. And it was a very big struggle for me. But, you know, some of their bigger cities like Toronto, Edmonton, like, they have some of the best research and universities in the world, you know, for healthcare, some stuff. So I think some of that is where, they try to focus a lot on preventative medicine, which we don't always do the best on that in our system. I will just say that, but it's nowhere near perfect. And then their acute services are not always, you know, I'll just tell you, I worked there, so I did operations, and then I was the director of operations for all health authority, and I had to be in charge of all the trauma and, like, orthopedic and surgeries and all that. So of course everybody's horror stories, like, you have to wait 18 months for a knee replacement, is 100% accurate. Yeah. So I would have a census of like 120%, meaning I had, you know, 15 people sitting in an emergency room, and I had no beds upstairs, and I had 4 people having a total knee replacement that day that needed a bed, and I had no beds for. I did everything I could to make sure they went to the OR, because most of them have probably been waiting 1.5 years or 2 years for a knee replacement. So,
The other thing is, how much dialysis do they do up in Canada?
same as here,
Yeah.
pretty much. So it's a lot similar in things, because folks don't deny, you know what I mean? Like, a lot of docs won't deny care. They worry about being sued. You know what I mean? Like, there's a lot of that too.
Do more
So
tests,
there's
same
still
test over
some
and over.
futile care, and there's still some stuff like that. You know, so there's a lot of similarities in that, and they do dialysis very similar to here. And actually, my dad's a chronic renal failure patient, but he hasn't gone to peritoneal or HD, but he was prepped for PD a few years ago. But there was no question, you know, on any of it. If he needs it, he'll have it. They do have one thing. Is they do have assisted death, and that went into place before I left in 2016 or 17, and that is quite popular right now. And you just can't, like, I'll just tell you that in my immediate family, that, we've had 2 in the last year that have had assisted deaths. An ALS patient, and, lung cancer. So, actually 3, and a gallbladder cancer. They pick their time when they get to a certain, and they pre-do all that before, so that when they get to a certain point, they just, but I mean, it's very regulated and all that, but there is that piece that we, you know, that we're not there yet.
You are board certified as a patient advocate. What is that board?
So it is, I think it's BCPA, I think if you look it up.
That's after your name?
Yeah, that's after my name.
But what is it?
But it is a national board certified patient advocate, and we all have to take an exam. Is that what you're asking me? So,
I'm asking, who is the board?
so the board are like physicians, other patient advocates, and they rotate
What's the
through.
name of the board? I mean, what's the
I have to look it up.
credentialing agency?
Isn't that terrible?
Yeah.
It is, I think it actually is board certified, like,
Patient advocacy.
it is. And then I get mixed up because I have that.
And you, I don't have to know right now.
No, it's okay. I should know it.
And the same for nurse executive.
So the nurse executive is with the American Nurses Association, so it's the ANCC, and that one I do every 5 years.
Yeah.
And it's all like, and the same thing with board, the patient advocacy, like David and I have to do continuing ed hours, and we have to do ethical eds, and we have to do, some of our nursing and respiratory therapists cross over,
Yeah.
but, not all of it, so, I'll have to tell you
Okay, that's fine.
after.
We can Google it.
It's
The
board certified
Google
patient
it.
advocate, board certified patient advocate. That's what it is, board certified patient advocate. I think that's the website, yeah. Patient advocate certification board. So
Okay.
it's backwards, but that's it right there.
Yeah.
So,
Thank you.
and David and I we were the 3rd group to sit for the board. So it's
Since
not,
the
it
new-
hasn't
It's
been.
not real name.
It started, they had their first one in 17, no, their first 2 in 17, in 18, and in 19, we sat for the first ones in 19. And then, so now they do, but they're planning to, so it's growing, so they want it to be like, what they call, I think it's ICE certified, if I'm correct, and that is, basically in short, it stands so that it's a national recognized certification. But individuals, and when they opened it, they didn't have it open to, like, people could do it that didn't have degrees, but now they've had it, cause they didn't have such a success rate, so most people who do it have to have a bachelor's of some kind to do it, so so Dave and I both would, but we have to fall back into that renewal every year. That's the first time someone asked me that, I couldn't remember, to go back and look, I'm like, where is it? So, but.
So is it CE driven, that, you know, you are working in the field and you're continuing education as far as recertification?
Yes, and then also now some of the insurance pieces are coming on board with that, so the community health worker, if you remember, I talked a little bit about that. Medicare has just announced, and so they just started in January of this year, as a community health worker, and actually they're under they look at patient advocates have to work X number of hours in the field, or you have to be certified within your state to be, but because Dave and I are board certified and we have the 5 years of our open business, then we would automatically be certified as community health workers for the insurance reimbursement piece. And I'm actually getting ready to, so there's a place called solace.health, SOLACE.health, and they're a national patient advocate site, and we actually sit on that, David and I do. And that's, sometimes we get referrals for there for all over the country. And they're actually going to do the reimbursement for community health workers for the underserved throughout the country. So we're actually, and I'm supposed to be going in to do that orientation. So I'll sit on that national to be able to do community health workers. But the thing about that is, So that's so very different from our business. So I just told you, like, I can do pretty much anything, right? In business. I could be the other daughter. So,
Yeah.
you know, we're going, so I have one client right now that we're doing taxes. So not only are we making sure bills are paid and he's taking his meds, like we got our piles put together for his CPA, right? Because I help with anything but the community health worker reimbursement piece through Medicare will be very structured.
Yeah.
So it'll be, yeah, you know, from the shipping, it's going to be mostly an education piece and hopefully some navigation, but that'll be, what I would love to see in that piece is we're able to help the underserved, the folks that I can't take on as clients because I can't afford to take them on. If I can at least get some money from Medicare or Medicaid, then we could at least help individuals like that,
Well,
right?
and I'm just saying this out loud, it sounds like it's starting out in silos, which usually happens with all of these different,
Yeah.
you know, credentialing and certifications, and people can do this and people can do that. But I would ultimately love to see where there is that there's a comprehensive program for patient advocacy that can certainly provide, but you would have certain people that would be experts.
You're right.
Like, you know, as SMEs, I call them SME, you know, certain,
Yeah.
the.
And that would be
subject
like,
matter experts.
that was kind of where David and I went when we started. I know we're kind of off topic, but that was kind of why we didn't want to specialize in our business. You know what I mean? Like we wanted to keep it open because I wanted to see anything and everything that somebody could throw at us, so that at some point, if we got to the platform to be able to talk about what the needs are in healthcare, then we're very versed to be able to talk about why people, you know, look for a patient advocate, why they need, you know, what the use, you know, where we're used and what the frequency is, and we're not just giving them data from like one stream. You know what I mean? Like, so that was ultimately our goal when we did it. You know, of course, because we came in with the big dreams and goals to be able to, you know, everybody should have a patient advocate, right? And if you don't have one, you should be able to get one. And it should not be a money piece, because everybody, you know, healthcare is a basic need, just like transportation and shelter and everything else. So, and we do save people money. Like, we do keep people out of the ER. We do keep, you know, every time we keep someone out of the ER, they save between $17,000 to $35,000 a visit.
Yes.
Like, that's huge. If the hospital was paying us $2,000 for someone that was what they call a frequent flyer, I mean, they'd be saving themselves about $30,000 to $40,000 a month on one person.
Yeah.
You know, so there are some really good potential pieces to be able to, but it's just like you said, right? It's those silo pieces, and trying to build a like a big program is much more. We might not see it, but we might be able to contribute to it at
I just
least.
hate the federal government.
I assume that most of your clients come to you when there's an emergency or a problem.
So
Do you have many clients who come in advance?
So
in
we have the two, and
anticipation
that's
of-
that kind of, so our goal is any patient, any place, anytime, and then we split from a crisis to a preventative.
Right.
And that's kind of where we're at with that. A lot of times we get one person in crisis, and then the other family member will jump on as a preventative, right? Or we get folks that hear us in these kind of platforms. We've got a couple folks that don't have children, you know, and we have other folks that their kids live away, and they're like, this is great. Like, my children have been wanting me to do this. I just need to, can we just get set up, and then if something happens, we have you. And we have a fair number. I've probably got 50 or 60 people like that are in our database, that if we, you know, they're good, we go through everything. They're okay, but if they need us, then we're there. That kind of thing, so. Are we good?
Yeah, we're good. Yeah, you've done a great job.
So,
Thank you.
You're welcome. I know, that's why I said time flies, right? It's already 12 o'clock.
Yeah. So obviously, there's probably gonna be a lot more, what would you do if, questions.